Welcome to Medical Logistics 101 Tick Bite Overview. This video is for educational purposes only. It is not medical advice, does not replace a medical evaluation, and may not apply to your situation. If you have symptoms or concerns, please speak with a licensed healthcare professional. My goal is to help patient-centered healthcare with a map instead of a blindfold and to explain how clinicians think through these problems in resource-limited settings. Today we'll be doing a tick bite overview. You have to distinguish between hard versus soft ticks. Common U.S. species, Ixodes, Amyloma, and Dermacentor. Local reaction versus systemic infection. Transmission requires time attached and varies by the pathogen. Signs and symptoms. Local symptoms, typically small erythematous papule at the site, mild pruritus or itching, local swelling, retained mouth parts, sometimes seen. Signs and symptoms. Systemic symptoms that are worrisome: fever, headache, muscle aches or myalgias, fatigue, rash. Pattern varies by the pathogen, and sometimes GI symptoms. Exam findings: tick present or recently removed, local erythema versus an expanding rash, lymphadenopathy or swelling of lymph nodes in the region, petechial rash, typically seen in Rocky Mountain spotted fever. There are great examples of that online. Erythema migrans, Lyme disease, kind of a classic rash associated with that, also great examples online. Jaundice or pallor, seen with Babesia. I don't typically see those very often, but that is one to keep in the back of the mind. Neurologic findings, this would be tick-borne encephalitis, late Lyme disease. Again, not common, but you certainly do encounter it sometimes. Tick-borne diseases: Lyme disease, vector Ixodes tick, region northeast U.S., upper Midwest. Key exam findings: erythema migrans rash, arthritis, sometimes neurologic symptoms with Lyme disease. It can really be a wide range of symptoms with Lyme disease. Rocky Mountain spotted fever, vector Dermacentor tick, region southeast U.S., south central U.S. Key exam findings: fever, headache, and again that petechial rash, which is kind of a late finding, one you really want to catch because there's a high mortality with Rocky Mountain spotted fever if treatment is delayed. Tick-borne diseases continued. There's tick-borne encephalitis or TBE virus, rare in the U.S., but it is important for travelers. Region is Europe, Asia. Kind of has a biphasic illness pattern, can progress to a neurologic phase. And then, of course, alpha-gal syndrome, vector Lone Star tick, key delayed anaphylaxis to mammalian meat and sometimes gelatin products. I have seen people who had a known history of alpha-gal that had severe reactions to even gelatin capsules when they were taking medications. Had to be very careful on what medications they took. Growing problem in the Southeast and Midwest. Diagnostic studies: key rule, early serology is often negative and diagnosis is clinical usually, at least initially. These tests are usually lab send out, so it may be a while before you get the results. For Lyme disease, the ELISA Western blot positive after 2 to 4 weeks. Rocky Mountain spotted fever serology can be negative acutely. Sometimes a convalescent period is needed before it would be positive. Ehrlichia PCR, early positive sometimes. Babesia smear or PCR. CBC, I usually would get one if I'm getting labs for tick-borne illness. I'll get a CBC, which oftentimes may show thrombocytopenia or low platelets and leukopenia or low white count. The CMP, you may see elevated LFTs. And the UA, you may see hematuria, particularly with Babesia. Red flags: fever plus rash plus headache would certainly be a red flag for me. That petechial rash seen with Rocky Mountain spotted fever in particular. Neurologic symptoms such as meningitis type symptoms, hemolysis signs, severe abdominal pain, hypotension, which of course would make me think about sepsis, of course, very young, elderly, or immunocompromised patients. Pitfalls: assuming no rash equals no disease. Waiting for serology before you treat. Missing ticks on exam. Rocky Mountain spotted fever and ehrlichiosis are kind of a higher risk category for me. Misidentifying the erythema migrans rash with Lyme disease. Testing too early. As I said, it may take time before those tests are positive. Missing alpha-gal and unexplained allergic symptoms. Sometimes patients have had a tick bite in the past. Maybe they didn't have much in the way of symptoms at the time, may not recall the tick bite. Not treating empirically when you have a patient who's in a high-risk geographic area and having symptoms. Disposition: home care, usually if it's a local reaction only, there's no systemic symptoms such as fever or exam findings to suggest sepsis or meningitis. Making certain you have proper tick removal. That sounds like common sense, but oftentimes I've seen these patients and they've had multiple ticks attached and they've removed the ones that they saw, but there could certainly be ticks in areas that they didn't catch. Education on the warning signs of systemic infection with close follow-up. Admission, I would typically admit if there were neurological symptoms, that petechial rash, again with Rocky Mountain spotted fever, hemolysis, or systemic symptoms such as fever, headache, neck stiffness, any of those symptoms, I'm typically going to admit those patients. Very young patients, elderly or immunocompromised would be higher risk patients, obviously. In closing, if this is the kind of content you find helpful, please like and subscribe. If there are topics you would like to see covered, you can email me at medicallogistics101@gmail.com. Remember, the danger isn't always what you know, but rather what you can't afford to miss. Thank you.